Welcome to the Diabetes Podcast. Today we're joined by Dr. Sajid Khan, medical doctor and master of public health, an endocrinology-focused family medicine physician with over 15 years of experience helping people navigate diabetes, thyroid disease, and metabolic health. Dr. Khan is certified in Eversense continuous glucose monitor insertion, is an American Heart Association advanced cardiovascular life support and basic life support instructor, and an educator who trains both patients and clinicians on the latest in continuous glucose monitoring and insulin pump therapy. In this episode, Dr. Khan shares why he leans into technology to make life easier with diabetes. Think automated insulin delivery, tubeless insulin pumps, and CGMs that turn data into daily decisions. We get into why more people with type 2 diabetes are moving from multiple daily injections to pumps, how he helps patients overcome fears about insulin, and what truly prevents complications over the long haul. You'll also hear his refreshingly practical take on remission, motivation, and the very real impact of our environments on weight and blood sugar. If you or someone you love has ever wondered whether an insulin pump or CGM is worth it, how to talk about insulin without stigma, or which meds matter most for kidneys, heart, and eyes, this episode is for you. Let's go. Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today we're joined by Dr. Sajid Khan. Dr. Khan, welcome to the podcast.
Thank you for having me.
So, Dr. Khan, I'm curious, in the field of medicine, endocrinology tends to be the lesser of the specialties in terms of salary, in terms of work-life balance. What is it that drew you to endocrinology?
Well, a lot of things because I believe like hormones control us, and not many people were doing this back when I was doing the training, and I felt that this is a area of need, and definitely wanted to help people out. And small chemical shifts can make a lot of changes in one's life.
Awesome. So along those lines, I noticed at least now you're mostly focused on diabetes. And in my experience, most endocrinologists do the pituitary disorders, the thyroid hormone, thyroid function, and don't do so much diabetes. They kind of give that over to the nurse practitioner or the physician assistant. Has it always been so that you've been more focused on diabetes, or is this a more recent thing?
No, I've always been inclined towards treating diabetes more than other providers, primarily because I feel there's a lot of technology involved these days, a lot of new tools coming in diabetes these days. And I love that part. I mean, really, I think we can make our lives much more better and, you know, overall more efficient way of doing things by using technology. And that I felt was frankly missing. Most doctors are not really aware of using technology, or they don't want to use the technology for healthcare. And there is a lot of learning curve, reluctance, and all those combinations. So I felt that there's a lot of gaps, and I can definitely fill those in.
Absolutely.
Is there any particular technology that you're really excited about as it relates to diabetes care?
Yes, I mean, one of the technologies that we are using in our clinic a lot recently is Omnipod, which is an insulin pump that recently got approved for type 2. Previously, the pumps were only approved for type 1 diabetes, uh, and now it's approved for all kinds of diabetes. The type 2 forms the majority of the diabetic patients.
Awesome. Awesome. So what outcomes have you seen with that? Like, what's the difference for you between progressing someone? Like, a lot of providers I've noticed try to keep people off of insulin by using an SGLT2, a GLP-1 receptor, and a receptor inhibitor, excuse me. But on yours, it seems like you're leading more towards early insulin initiation. Is that just to preserve the beta cell function, or what are you noticing, and what's chosen you to be very aggressive with this related to your peers?
Well, I think, I mean, I would still want people to be off the insulin, and if we have the GLP-1s, which are excellent drugs and have helped a lot of people to even get off the insulin. So, yeah, I'm not necessarily in the favor of more insulin, but if anybody's doing insulin, we want it to be doing it in the right way using the pump. I mean, because pumps can save lives, and manual shots have historically been, source of a lot of problems. I mean, some people sometimes forget about it, sometimes they overdo it or underdo it, but uh, definitely whoever is doing insulin, I think they should be on the pump. And uh, the other reason why we try to get people on insulin is the side effects. I mean, insulin is a naturally occurring compound in our body. I mean, if anybody is having side effects to the medication, obviously there is only the best option that remains that is free from side effect is insulin. So yes, a lot of my patients, we are trying to get on insulin when they're not able to tolerate any of these new drugs or the GLP-1s or SGLT or any of the drugs. I mean, ultimately, the last resort, I mean, the drug of choice with something that has almost virtually no side effects will be the insulin. So yes, we have a lot of patients on insulin because of that reason.
I'm curious, are your patients, like, I would imagine that no one is like, yay, insulin. I was hoping that my doctor would say it's time for insulin. So, how do you navigate that conversation with patients in a way that is, I'm your physician, I know what's best, this is the next best course of action, and also respecting any kind of preconceived notions they might have about insulin being a failure or anything along those lines? How do you navigate that?
Yeah, I mean, patients have all kinds of biases towards insulin, or some patients are okay with insulin. So really, I have had patients who are like, they want to do anything but insulin, like, and while other patients are like, okay, I will go ahead and do the insulin because I'm having so many problems with the existing medication. So yeah, I mean, we do have, both kinds of patients. Some patients who are like, I will feel like this is a defeat if I accept insulin. I don't want any needles inside me. Well, I will try to come back changing the lifestyle. I will see you in a few months, and I will promise this time I will behave better and I will try my best. And for some patients, it might work. I mean, but it's not a recipe that can be done with every single patient, because we really have to customize as per the patient's needs, as per the patient's response to the medication. So there's lots of factors that are coming into play, that will decide us what to do next.
Yeah. Do you find that a really difficult part of the discussion with patients? Like, there's so many factors that you're considering that didn't even enter into the realm of what they might understand about what diabetes is and how it's treated. And so I guess my question in that is, like, it sounds like a lot to navigate. What do
Yeah.
you find works best in terms of someone who you see for the first time versus the second or third? Are you more likely to just give them what they need right off the bat, whether it's whether it feels abruptive to them, or is it really just about treating them the best no matter what?
No, I mean, I will stick to trying to go for the best. I mean, really, if you see, there's a lot of complications from diabetes, and that is what our aim is to prevent. I mean, I tell patients, like, our aim is not just to lower your sugar, but to prevent the complications. So there are drugs we use in diabetes, like lisinopril, the Ozempic, the Farxiga, the Jardiance. They prevent you from developing these complications. So ideally, I would want them to not just be completely focused on lowering their blood sugars back to normal, but also to have a control on, and if possible, prevent all those complications. So if we know that some of these drugs are going to prevent the complications, then my priority is for them to get onto those drugs, not on those drugs which can lower the blood sugar, but not necessarily have any, survival benefit, not necessarily have any benefits with the preventing the complications.
Absolutely. Yeah. So you had mentioned that, of course, if somebody could achieve diabetes remission, that's something that would be great. How often do you actually see that happening? And or what kind of patients do you notice it in more than others? Do you see any kind of a trend?
Yes, I mean, obviously, type 1 diabetes is not reversible. There's no way
Exact
that
right.
anybody
So
will.
glad that you pointed that out.
If somebody's got type 1, their pancreas are toast. That means there is nothing out there. There's no insulin getting produced in the body. So type 1 is irreversible. But for type 2, the chances are almost 75% if they are overweight or obese or having too much body fat. If they lose their weight, if they lose the body fat, there is a 75% chance that they might get rid of diabetes altogether. But having said that, there are still 25% people, which is a big number as well, that even with zero body fat, they will still have diabetes. So it's not 100% guarantee even for type 2, but chances are good. But for type 1, there is no chance that they will be able to reverse the diabetes.
Got it. I'm curious for that percentage of lean people with type 2 that can't achieve remission no matter what. Do you think that maybe they actually have type 1.5 diabetes? And I'm asking because we just did a podcast a few episodes ago about type 1.5.
Yes.
And like, is that who you see kind of not able to achieve remission, who were maybe first diagnosed with type 2 or?
No, these are just the pure type 2, but they're not producing enough insulin. So their
Got
pancreas
you. Okay.
I mean, their pancreas are kind of not producing let's say if you need 100 units, they're only producing 40 or 50. So that's what these patients will need help regardless of whether they lose the weight or don't lose the weight.
Do you associate that with just kind of perpetual damage to the beta cells over long periods of time to where they just can't recover? Is that kind of what you're thinking?
Yeah, there's a lot of research going on. We don't have a solid answer yet, but that is one of the possibility. But also the other possibility is the amount of resistance they have. So let's say maybe they're producing the 100 units, but it's not working because the receptors are kind of damaged. So those some of them fall into that category, some of them fall into not production category. So there's a lot of different kinds and things in there.
So, along those lines, do you believe that insulin therapy can be a bridge to remission? Or do you see that by the time somebody probably needs insulin, it's because their beta cells are? I feel like this is a too many part question. I'm sorry, but I'm just curious. Is that why you try to initiate insulin early? Is it really based on preserving the pancreatic beta cells, or is it because they've failed other oral or once weekly injectables? What's the main
Yeah.
driver there?
Really, those, as we discussed before, the side effects are number one reason why we switch a lot of patients to insulin because patients are not able to tolerate. Every drug comes with whole list of side effects. When they go on reading, some of the patients will themselves will say, "I don't want to do this because I see those huge list of side effects, and I'm a very sensitive person, so I don't want to do this for a period." They just move to the insulin right away. But a lot of patients, insulin is an add-on in addition to those medications, in addition to Ozempic, in addition to Jardiance, in addition to all the other medications they're taking for diabetics. We are just putting like an add-on to bring their blood sugars to where they should be.
Have any of your patients been able to achieve remission? I know the answer to this. You said they have, but I'm curious, like, do they still see you after they achieve remission, or do you never see them again? So you don't really know like how that follow-up is. What does that look like?
Um, Yes, we have had remission, but again, we did also have some patients going back and forth too. So they got rid of diabetes, they got everything in control, but then they gained the weight back and the diabetes came back right in. So yes, we have all kinds of patients and who achieve remission and they're still coming back. And yeah, I mean, if I feel that they're able to maintain it, they're able to have like a permanent remission. I try to do like a 6 months follow-up for these patients and just to see how they're doing. And if they're doing fine and if they don't need me, yes, we stop following them altogether. But we do try to make sure that they're completely out of diabetes and the chances of going back into remission and again are low, really low. Yeah.
Of the ones that have been successful, is there a thing that differentiates the people that are able to keep the weight off versus the people that kind of yo-yo weight stuff is not uncommon even outside of the diabetes realm? I mean, that's kind of the normative American condition. We try a thing for a while and then we go right back. What's making certain people successful and the rest of them not so much?
Well, it's kind of difficult because everybody is different, every person is different. But obviously, one thing that I have noticed is the motivation. I mean, how motivated they are before starting the treatment, how serious they're taking it, how much they want to change their lifestyle, their behavior, and how much effort the person is putting into it. Not just depending on the medicine itself, but they're actually putting their own effort. So, more effort, more time, and more motivation are the key tools to keep it more sustainable.
That's not an easy answer. I think that's going to disappoint some folks. What I'm hearing is more effort is better.
Yes, because ultimately we have to understand the obesity, the weight issues have a very strong genetic component. I mean, there are people who are gaining weight by just eating small amount of food, while there are other people who are eating all the food in the world and they're still, not gaining any weight. So there is definitely a strong genetic component. The obesity gene is widely agreed upon one of the most important reason why people gain weight. So unfortunately, a lot of people come back because of that gene, and that's why I tell patients choose your parents carefully. So.
Choose your parents carefully. I think the research shows something like a 10 to 15% genetic component for certain. And then there's also this idea of an obesogenic environment with processed foods, a sedentary lifestyle. Many areas. I think you're very well traveled, Dr. Khan, and you probably noticed that some places are much better suited to riding bicycles and walking versus Florida, where you have to drive everywhere you go. 2 blocks down, you have to drive or you'll get run over. So do you believe that the environment plays a really big role as well?
Yes, and some of my patients when they come in, they say, "Hey, I'm overweight because I'm Italian." And and I told them I've been to Italy, and people there are really slim. I mean, most Italians are not as heavy as Americans. So I told them like, it's not that you're Italian, it's that you're American. That's the denominator
You
here
like
because
refined pasta and refined white bread. Yes.
people over there, I mean, when they drink a cup of coffee, it's tiny. It's like this size, and you 2 sips and you're done. And if you go rest of the world, most of the places is like that. And then the coffee cups are tiny. When you come to US, I mean, the smallest size is probably 5 times bigger than what the rest of the world drinks. So yes, America is definitely it's got a culture, and we really try to go big for everything, and that is a problem. And Um, yes, as you said, walking and having a good walk score. In fact, there's a website called walkscore.com. You can calculate you can put in the address and get a walk score. And most of the Americans,
Walkscore.com.
yes.
Okay,
Uh,
got it.
yeah, and most of the American cities, they don't have good walk scores, and meaning that you cannot just go walk and get things around your home. So that's a pretty common thing for majority of the people here, unfortunately.
Very true. Very true. Okay, I'm going to shift a little bit to health literacy and digital literacy. So when you talk about introducing more of these advanced automated insulin delivery technologies, what does that look like in a rural setting? Like, how do you address these health literacy and digital literacy issues in your
Well,
practice?
I think we have a lot of patients that come in Marion County and uh, that have been taking insulin since forever, and I had no idea about the pumps. And I am not surprised that every week I come across one or two patients like that, and they were not even aware that pump exists. Pump was never offered to them. What is even more surprising to me is even the type 1 patients who have never been on
Yeah.
pump. And the pump has been there since 1980s, and yes, it was very rudimentary and very primitive in the late 80s, but uh, I mean, in the last 5, 10 years, we have tremendous increase in the technology, and Omnipod is one of the pumps that we frequently use, and almost we have 4 to 5 patients who are getting on Omnipod training every single week in our clinic, and we have excellent results. Well, every pump company claims that their pump is the best, and Medtronic claims the same thing, Tandem claims the same thing. I mean, but really, there's not like a whole lot of difference between these pumps. They are pretty good, all of them. But Omnipod, on the other hand, has this tubeless technology, wherein you don't have to, you don't have any tubes coming out of it. There's no wires coming out of it, and you don't have to take it out while you're taking a shower or you're swimming. So that is the convenient. I mean, it's really the convenience that patients are looking for. And overall, I'm pretty satisfied and happy with this new technologies coming up and educating patients on this who were never educated. That is one of the most satisfying part of the job. And like the patient is like, all my life, I have been doing 4 to 5 shots every single day. And nobody ever told me about this. I am so thankful to you, doctor, because
Yeah.
how come I never knew about this? That was available to me, that was right there, and you're right here, and I never ever came across this device, and nobody ever told me about it. So really, it's strange that we are living in such advanced times, and yet a lot of patients are not aware of this, and these tools exist.
Yeah. I would imagine you hear that a lot. Like nobody ever told me. Not
Yes.
not just in relation to Omnipod or AID systems, but like just in general, because you are such a progressive physician, like you're so progressive in the way that you treat patients. I would imagine you hear that in other things as well.
Yes, and we try to be up to date on technology, and we are using all the new tools that we have, and we keep an eye on latest FDA approvals and diabetes as well. As soon as any device or any product or anything out there gets approved, we try to incorporate that into our clinic. Like recently, we have incorporated an inhaled insulin, even though we have not yet started anybody on it, but we want to give the patients the option that it's there. So if you're scared of shots, you're scared of any kind of insulin, maybe you can inhale it and see if that will be a good fit for you. So in the same way, we have we were kind of when I came to this clinic 2 years back when we started this, nobody in the clinic was on this Omnipod pump, and I basically called all the companies, and we wanted to them to come here and start working with our patients, and that's the thing that worked because really, um, patients find it so helpful that we have all the choices in our clinic, and they can get to pick up what's best for them.
It's awesome. Awesome. So the new ADA, the newer, I guess I would say, the ADA guidelines came out and they recommend AID therapy for all insulin dependent individuals. And you really have you seen those guidelines? Is that what changed your care, or were you already on that path before it sounds like you were already doing that before the guidelines came out and really supported what you were already doing?
Yes, yes, and I was also when I saw the CGM, and I was already on that path that I was pushing more and more patients to get the continuous glucose monitor, pushing more and more patients to get the automated pump because I've always been inclined in using technology and automation. And really, it's such a hassle when you have diabetes. It becomes like almost like a part-time job to manage your blood sugars. If you have one less thing to worry about, that will be really, really helpful for the patient. And also the amount of stress you are undergoing by having these 5 injections every single day. You have to store them in the fridge. You have to store them in the right temperature. You have to carry it wherever you go. You have to have a cooler bag, put an ice pack in it. It's such a hassle. And, really, patients, nobody should go through this. And that is why I was always inclined to use the pumps, and I've always been using the pump. But now that we have the type 2 approval, that means any diabetic patients can get this right now, whoever is on insulin. That I've made my pledge in the office that none of my patient should be doing manual shots. That is like such an old way of doing it. And if I see that, I said like right away tell them like stop. We don't need to do this. And we have switched almost I would say 95% of our patients to the automated technologies.
Awesome. So that is not the same mindset that every endocrinologist has. And it's absolutely not the same mindset that every general practitioner or internal medicine physician has. If you could impress something upon them in this area, because of course it's related to fear. It's usually a belief that they need to be carbohydrate counting first, or the pump could do something weird and malfunction and give them too much, or it's too complicated. What would you say to those physicians who are still apprehensive, let's say, about moving forward with this technology and getting patients off shots?
I would like to say that, really, shots are definitely something that we have been using it for a long time, but this is going to make life easier, not difficult. I mean, a lot of physicians and providers have this fear that I don't even know what this thing is. I don't have any idea about this. And learning this from scratch and trying to understand this technology, that looks like a barrier to a lot of people. But, you know, from my experience, this is an easy tool to understand, not very difficult, and it makes life easier for both clinicians and the patients at the same time. It's not like it's just good for patients, but it overburdens or makes life tougher for physicians. That's not the case. It makes life easy for both clinicians and patients in the same way.
Awesome. Can you expand on that a little? Because I have an idea of how you mean it makes life easier for you. But in your own words, how does it make things easier for you versus shots?
Well, the biggest challenge for clinicians is to improve the blood sugars, to have a better control on the blood sugars. So, what we are trying to do is trying all kinds of different things, and that sometimes is a complex thing, and we keep adding more units. We increase the units in the morning, decrease the units in the night, and then the patients gets confused. Sometimes even the doctors get confused when they are doing that. Okay, how much are you taking in the morning? And what if there's a wrong data entry? What if there's all kinds of error, there's all kinds of error while writing in the directions, and that makes the clinician's life a lot difficult. I mean, the writing that direction for insulin could be a nightmare for a lot of clinicians. While with the pump, the prescription errors and all those intricate details that you used to do with writing the prescriptions has gone. I mean, you don't need to micromanage on the adjustments and the dosages and all that, because the pump is automatically going to do it. So really, that is what I feel is it's a easy part, because every time the patient comes in, it's such a burden to see that five different shots, and you have to know how much units on every shot, and then you have to calculate, and then you have to adjust. That makes it so difficult. With the pump, you don't have to do all of that. The pump is automatically going to do it for you. So definitely making life a lot easier for you, not difficult.
Awesome. Awesome. Is there any particular patient that has really tugged at your heart, or is there any success story with a patient that you feel like, yeah, that is why I get up every day and I do this? And I mean,
Yeah.
it's probably many, but is there anything that comes to mind?
Well, yeah, I mean, as you said, we have a lot of them, and every few days, as I'm surprised, like in this day and age, we have so many type 1 patients. They are like really, 65 plus, 75 plus even, and have never been offered pump. They were never aware of the pump. And really, when you see those, you're like, oh my God, this patient is type 1, and all of his life he's been doing that. And then as soon as they've switched to the pump, they're like so thankful and so happy that we did all that. And a lot of them bring us the sweets and chocolates, and I tell them like, you're not supposed to eat that.
They're like, but now I can give insulin for it. And yeah, I love it. I love it. So, can you tell me if somebody is listening to this today and they're newly diagnosed and they're feeling just overwhelmed with that diagnosis, what would you want them to hear from the perspective of an endocrinologist, from your perspective, about what they're about to be up against or see and live through?
Well, first of all, I'm sorry for whatever happened. I mean, however they develop the diabetes, whether it's genetic, whether it's a lifestyle, whether it's a combination of all of that, it's an unfortunate thing to happen. And it's not easy to manage diabetes. And it becomes more difficult over the time, and especially if it is not under control. But having said all that, we do have tools. We have much better tools these days to manage diabetes more than ever. I mean, if you would have come to me 15, 20 years ago, all we used to do is pills, and I mean, there were also very limited amount of pills and limited amount of treatments, and but now we have more tools than most other fields, and we have so many different treatments available. We have so many things that we are using, that we are preventing these complications from happening. And that is the key to managing the diabetes, to prevent any complications. And if you have diabetes and you have not developed complication for whole of your life, that's it. You have beaten the diabetes. I mean, really, you don't need to worry about that, because it really, the target organs with diabetes are your heart, your kidneys, your eyes, and your feet. Those are the top four, what I have seen they're getting involved. And if we are able to use all these tools we have to prevent any complications wherein the patients do not ever have to go blind or have heart attacks and strokes or kidney failure or even amputations in the feet. I mean, that is what our aim is, and that is what we have been so much successful in doing. and preventing complications at our clinic using all these new tools, technologies, and new treatments.
Absolutely. Absolutely. Wow. I think I've run out of questions. Is there anything that you want to share on your own, or anything that if somebody's listening to this, you would really want to impress upon them besides kind of really the good stuff that you just said?
Yeah, I mean, as I said, one of the most important thing when we are treating diabetes is to prevent complications related to diabetes. And I see so many patients coming to me having high blood pressure, and they are not taking lisinopril, which is one of the drugs that is an extremely important medication to control the blood pressure. So
And
patients will.
quite, I'm sorry to interrupt, quite inexpensive, correct? Like no matter the insurance, it's pretty inexpensive. Yes or no?
No, it's not an expensive drug, but it's like $4 prescription. So we've been using it for ages, but I still see some diabetics never on this blood pressure medication, even after having high blood pressure. So this medicine is known to prevent kidney failure from happening. And a lot of my patients are not on it. And same thing with the, other things other medications we talked about. So if anybody is at risk of developing heart problems, and we really want them to be on Jardians, and if they already develop kidney disease, we don't want it to progress, so we want them to be on Farxiga. So these are the steps, and these are the minute things that can make a whole lot of difference in anybody's life. And that is why I think going to the right place and getting the right treatment and preventing any complications is crucial to managing of diabetes. So for all the diabetics, I would say that is the key message, that go to the place where you have the best chance of preventing any complications, and that is how you can effectively manage the diabetes.
I love that. So speaking of going to the best place, anyone anywhere within driving distance who would like to see you, Dr. Khan, how can they find you?
Well, we are available. I mean, the problem right these days is the insurance. I mean, a lot of insurances are blocking patients directly to coming to us, and they want the referrals to be made. So, I mean, ideally, I would want you to get a referral from your provider, because I don't want them to just directly make an appointment and then get disappointed that they cannot come and see me because their insurance won't approve it. So ideally, I think talk to your primary care and talk to and tell you can tell my name and my location and address and phone number, whatever you can find on me, and then you can get referred to us.
Man, you bring up such a great point, and I think you probably stepped on a nerve the minute you said insurance and referrals. But I think with everything that you've said today, patients can really see the value in taking the steps to make sure that you're covered under their insurance. It's open enrollment for Medicare right now, so that would be important to look at. Do you have any other place where people can find you other than, so you have an office in Ocala, you also have an office in Lake City, Florida, is that correct?
Yes, that's correct. And those are the two main locations we have right now. We might be expanding and having another location in Highway 200 next year. That's in the pipeline.
Wow. So you found out how to clone yourself. That's awesome. Cloning technology.
Yes.
Fantastic. Awesome. Well, thank you so much, Dr. Khan. It was such a pleasure to have you on. Just fantastic. I love hearing your perspective and the love and care that you have for your patients. So thank you so much.
Thank you for your dedication and to this and also your ability to connect to us and connect to people. I really appreciate you doing this.
Thank you much. Appreciate it.
Have a good day. Bye-bye.
Thank you for listening to the Diabetes Podcast, and we will talk to you again next week. Big thanks to Dr. Sajid Khan for an insightful look at modern diabetes care, and for reminding us that the real goal isn't just lower numbers, it's preventing complications and protecting the heart, kidneys, eyes, and feet over a lifetime. Key takeaways from this episode are If you're on insulin, talk to your physician about automated insulin delivery. Pumps can reduce dosing errors and daily burden compared to shots. CGMs aren't just data, they're guidance. Pairing CGMs with the right meds can change outcomes. GLP-1 receptor agonist and SGLT2 inhibitors can offer cardiorenal protection. Insulin remains a side effect sparing tool when other therapies aren't tolerated. And remission is possible for many with type 2, but motivation, environment, and biology all matter. Progress beats perfection. If you enjoyed this episode, please take the time to give it a like or leave a review. This really helps to promote and sustain this free podcast and to get the word out to the millions of people worldwide that are struggling with type 2 and prediabetes, that remission is possible if you take action today. Until next time, take courage. You can do this, and we can help.